rheumatological autoimmune disorders and their neurological manifestations. And I should say, this is really the first time that this symposium has addressed this subject, and it's a very important one because more and more of our members have these connective tissue disorders associated with their neurological disorders. So thank you. Dr. Birnbaum?
Oh, thank you very much. So just bear with me if we go backwards instead of forwards. It's a little wired up here. So I'm going to be talking about the neurological manifestations of lupus and other systemic rheumatological disorders. I'm going to start by focusing on lupus, and that's going to constitute about 80% of the discussion. I'm briefly going to touch base about antiphospholipid antibodies occurring in the context of lupus, and then we're going to move to Sjogrens syndrome, and then finally we're going to conclude with the primary systemic vasculitides. My training, I've done both training in neurology and rheumatology, so I've kind of had both sides of the spectrum, and it's been interesting to compare the neurological and rheumatic perspectives on these disorders. So just by starting out, lupus, like MS and Devic syndrome, is a clinical disorder. And really briefly, the classification schemes for lupus says that you need 4 of the 11 criteria. And neurological disorders, skin manifestations, arthritis, what's called serositis, which is painful breathing, renal disorders, various hematological disorders, a positive ANA, which is seen in other primary neurological disease and is nonspecific, and other markers of the disease, such as anti-double-strand DNA positivity. The face of neurological lupus was initially limited because, as first described, seizures or psychosis only comprised a neurological disorder. And as I'm going to get into, that changed. But the first part, what I want to engage is the paradox that most of neurological disease seen in lupus is actually not due to lupus per se. And I think the next 2 slides illustrates this. So patient 1, a 31-year-old actual PhD candidate who said that she was having trouble carrying out lab tasks. Her lupus was quiescent clinically and serologically for about 1 year, and she complained of mild worsening morning headaches. And we did an MRI, and the MRI done here shows dilatation of the 4th and 3rd ventricles, pretty significant hydrocephalus. She was referred for a VP shunt and actually did quite well. A 54-year-old female, history of lupus with active renal disease, treated with Cellcept, in remission, developed 2 months of worsening headaches and confusion. This MRI shows bilateral basal ganglia mass effect, and on biopsy, she was found to have a T-cell lymphoma, and she ultimately died. So the take-home point here is that there are secondary causes which are disproportionately seen in patients with lupus. These are very, very sick patients. They're immunosuppressed. The risk of infection is higher. They have a higher risk of metabolic derangements because of uremia, renal disease, other iatrogenicities. And so the take-home point here is, especially for neurologists, is a valuable role to identify these secondary syndromes, to really engage the rheumatologist. And a lot of times rheumatologists, they'll see neurological disease. It'll be something esoteric, something unfamiliar, and they'll kind of want to shoot from the hip. And kind of the role as neurologists is to say, wait a second, slow down. Let's see if there's a secondary disease, and let's construct a careful differential diagnosis. So let's say that's step 1 of the paradigm. Now we've eliminated secondary causes. The second goal is to define and diagnose primary neuropsychiatric disorders in lupus. So in 1991, the American College of Rheumatology came up with a classification scheme defining 19 distinct neuropsychiatric syndromes. I'm not going to go through all of them in great detail, but basically there are 8 peripheral nervous system manifestations of lupus and 11 central neurologic manifestations of lupus. These could be divided into diffuse and focal disease. For purposes of the discussion, I'm going to define diffuse disease as primarily cognitive or psychiatric disorders, those which really can't be localizable to a neuroanatomical nidus. And just taking a look at this, it's a little bit overwhelming, hard to digest, and I think for rheumatologists as well, it's ponderous, it's bulky, and it's not necessarily user-friendly. The other thing that I want you to look at is the diffuse syndromes, headaches, anxiety disorder, mood disorder. And these are syndromes that are seen in the general patient, non-lupus general patient population at large. In 2001, Ainala published a study in Neurology, and what he found was that 56% of non-lupus patients without any evidence of lupus disease met one or more ACR criteria for neuropsychiatric lupus. What he recommended, and I think this is a valid idea, is that the following 5 disorders should be eliminated from the ACR classification criteria of lupus. So in clinic, if I have a patient who looks pretty well and there's some mild self-complaints of cognitive disorder, headache, mild depression, anxiety, or an EMG negative polyneuropathy, what I'm going to say is that these patients should be treated as if I would treat someone who didn't have lupus. And you give them symptomatic treatment, but the important point is that you don't escalate immunomodulatory therapy, because as we saw from the patient who's on lupus nephritis and CellCept, the treatments that we give are dangerous and they potentially kill. So that covers the non-specific syndromes. As an example of a focal syndrome, I'm now going to move to how to evaluate one of the focal syndromes. How do I evaluate a stroke occurring in a patient with lupus? So the principles that are going to be distilled here could really be extrapolated to other focal syndromes, such as seizures. So the first point in the diagnostic algorithm is to ask yourself, what are the salient mechanisms which are causing the strokes? And the reason you ask that is because it has divergent treatment ramifications. So all disorders should be dichotomized as to whether there's an inflammatory or non-inflammatory etiology. The inflammatory etiologies which might cause strokes in a patient with lupus would include vasculitis and a small vessel angiopathy. However, the non-inflammatory mechanisms are equally as prevalent. Accelerated atherosclerosis. Lupus patients over the course of their lifetime have a 40-fold higher risk of heart disease, coronary artery disease, compared to the general population. Antiphospholipid antibodies are antibodies that are associated with strokes. They're seen in 30 to 50% of patients with lupus, as compared to 8 to 10% of the general patient population. Patients with antiphospholipid antibody syndrome in lupus have higher risk of what's called Lehmann-Sachs endocarditis, which is a non-infectious inflammation of the valves, which can dislodge and cause cerebral emboli and strokes. Now, interestingly enough, when you start subcategorizing strokes according to the size of the vessels which are affected, this provides a window into whether the underlying thromboembolic event is due to inflammation or non-inflammatory mechanisms. So a lot of times neurologists are consulted for strokes, and the question to them is vasculitis? Most of the time, the answer is going to be no. And it's a really not well known, but vasculitis is exceedingly uncommon in lupus, occurring in less than 10% of patients. Now, when it does occur, It's usually clinically transparent and manifests as what's called an acute ischemic encephalopathy. These patients are profoundly toxic. They have waxing levels of consciousness waning from lethargy to frank coma. They present with an asymmetric spastic quadriparesis. And also, there's usual robust serological evidence of active lupus disease, including hypocomplementemia and anti-double-strand DNAs. The differential diagnosis of this is antiphospholipid antibody syndrome, called the catastrophic syndrome, but catastrophic antiphospholipid antibody syndrome does not present with low complements. Large vessel strokes are also uncommon in lupus, but when they do occur, they're usually associated with active disease. So Levine in 1994 did a study looking at 30 lupus patients with symptomatic large vessel occlusive disease verified either angiographically or histopathologically, and found that 86% of these patients had active lupus. So this is one side of the spectrum. However, what's called lacunar strokes, or strokes of the smaller arteries, are seen with great prevalence in the general population. In the general population, the underlying histopathology is something called lipohyalinosis, and it's secondary to hypertension and diabetes, comorbidities, which are also seen with greater frequency in patients with lupus because of prednisone treatment. The rub here is that also in lupus, there's an inflammatory disease of the small vessels, an inflammatory microangiopathy. And it's worth thinking about this in the context of how lupus presents in other organ systems. In the skin, for example, this is immunofluorescence of a patient with lupus dermatitis. And here you see IgG and complement deposition along the basement membrane. Here's a renal biopsy of a patient with lupus nephritis. And the same thing, you see immune complex deposition, inflammation of the vessels, the capillaries in the kidney. The problem here is that you can't go ahead and biopsy somebody's brain. So what do? And the answer is not readily apparent at the current time. Unfortunately, right now, there are no good studies which associate clinical and serological markers of inflammation with small vessel strokes. So when I have a patient who presents with lupus and a Lacunar syndrome, it's really important to do a thorough surveillance of any background systemic and serological evidence of active disease. So that concludes a focal syndrome. Now, how do you go ahead and evaluate patients with diffuse neurological syndromes? And again, diffuse being primarily psychiatric or cognitive disease. The first step is the same as we identified before. Look hard for secondary factors. Again, uremia, infections, steroids, especially steroid-induced psychosis. These are all other entities which are secondary and which could cause psychiatric or cognitive symptoms. Let's say you've eliminated these secondary syndromes. Over the past decade, there have been several autoantibodies which have been paraded as putative markers of neuropsychiatric disease. And I'll get to some of them in the next slide. But the point I want to make is at the current time, these autoantibodies are limited by their poor positive predictive value, and they definitely require further studies in larger clinical trials. Evaluation of the CSF is more important in diffuse neuropsychiatric syndromes and focal disease, not only to eliminate infections. West in 1995 did a study in medicine in which he looked at 30 patients with diffuse neuropsychiatric disease, definitely attributable to lupus. And what he found was that in 27 of these 30 patients, there were abnormalities of the CSF. Abnormalities of the CSF being defined as specific antineuronal antibodies, oligoclonal bands, or elevated IgG index. Neuroimaging is only abnormal in 19% of patients with diffuse disease, and this likely indicates an immunologically mediated rather than a structural basis. So these are two of the autoantibodies that have been associated or reported to be associated with neurologic disease. Betty Diamond at Columbia reported a subset of anti-double-strand DNA antibodies cross-reactive with the NR2 glutamate receptor and has been associated in a single patient with dementia. Anti-ribosomal pre-proteins were the first autoantibody to be associated with a neuropsychiatric syndrome in lupus, and it's been associated in some case reports with psychosis and depression. Again, these both require further validation. Management of neuropsychiatric lupus is not well established and often empiric. There are no controlled trials establishing an optimal regimen. Often in someone who has severe or life-threatening neuropsychiatric disease, what we do is we treat them with the regimen extrapolated from the NIH lupus nephritis protocol, which includes IV prednisone and Cytoxan. Newer treatments for neuropsychiatric lupus might also be extrapolated from treatment of kidney disease. Cellcept, Rituxan, as well as more specific B-cell depleted treatments promise to be an important addition to our armamentarium. For antiphospholipid antibody syndrome, serial evidence of these antibodies in medium to high titers on serial occasions occurring in the context of either thrombotic or obstetrical complication warrants lifelong anticoagulation with an INR titrated between 2 and 3. So to summarize what we've talked about with neuropsychiatric lupus, a mechanistic-based approach is really important to really establish whether we're dealing with inflammatory or non-inflammatory mechanisms. For strokes in terms of focal disease, large vessel strokes, and a particular subtype of small vessel strokes, what I refer to as acute ischemic encephalopathy, is disproportionately associated with active disease. And kind of the dilemma, is these Lacunar Syndromes, which could be associated either with inflammatory and non-inflammatory disease. No good way of telling. When we deal with diffuse syndromes, a combination of neuroimaging and neuroantibodies and abnormal CSF helps to establish whether there's an organic basis for these syndromes. I'm going to move now to Sjogren's syndrome. And Sjogens syndrome is basically an autoimmune exocrinopathy, inflammation of the salivary glands or the lacrimal glands. Patients present with symptoms, complaints of very dry eyes and dry mouth. Dry eyes and dry mouth is a common complaint, so the diagnosis requires corroborating objective, functional, or biopsy-proven information. The CNS manifestations of Sjogren's syndrome is fascinating because clinically they could be very, very difficult to tease apart from MS. So Delande published a study in Medicine, and he found that of neurological Sjogren's syndrome, 60% had central nervous manifestations. Of these patients who had CNS manifestations, nearly 25% presented with a spinal cord syndrome of a progressive paraparesis, gradual, slow decline in gait disorder, which is difficult to distinguish from primary progressive MS. Now, nearly 1/5 of these patients presented, like you've heard before, with this characteristic multifocal relapsing course, which was difficult to distinguish from the most common type of MS, relapsing remitting MS. So how can we distinguish neurological Sjogren's syndrome from MS? One is by demographics. All patients in Delande's study for Sjogren's syndrome were older than 40, which is in contrast to the demographics seen in MS, usually between 20 and 40, and had a strong female preponderance, 80% of patients. Oligoclonal bands were only seen in 30% of the patients. One of the characteristic lesions of MS is corpus callosum lesions, but these lesions were rare for Sjogren's syndrome, seen in less than 20% of cases. Gray matter lesions are uncommon in MS, but were seen in nearly 1/4 of the cases with Sjogren's syndrome. In terms of autoantibodies, the ROLA autoantibodies have been promulgated as markers or prognostic markers for Sjogren's syndrome. But interestingly, only 15% of patients with neurological manifestations of Sjogren's syndrome had ROLA antibodies. Some of them had what is called an antifodrin antibody, and Sees and other people have studied whether this might be useful in serologically negative Rolo patients. A wide span of neuropathies could also be seen in Sjogren's syndrome. And Mori et al., he studied 92 patients with Sjogren's syndrome and neuropathy. The most common type of neuropathy was a sensory ataxic neuropathy. And this was shown on one autopsy study to be mediated by a T-cell ganglionitis. The second most common neuropathy is this really painful neuropathy affecting the smaller fibers. You heard me say before that vasculitis is pretty uncommon in lupus, not so in Sjogren's syndrome. The third and fourth type of neuropathy is a mononeuritis multiplex or multiple cranial polyneuropathies are mediated by infarcts, vasculitis of the vasa nervosum. And autonomic neuropathy was seen in all types of peripheral neuropathy. So I just want to reemphasize some distinctions between neuropsychiatric lupus and Sjogren's syndromes. They are neurologic manifestations. Neuropathy is not that common in lupus, seen 10 to 15% of cases, but can be seen in 50% of cases in Sjogren's syndrome. To reemphasize the point, vasculitis is uncommon in lupus, but mediates a vasculitic neuropathy in Sjogren's syndrome. And the MS phenotype is rare in lupus and is common in Sjogren's syndrome. So you've heard through the course of the day that various rheumatic disorders should always enter the differential diagnosis of MS and de Vick's disease. And what I want to emphasize is Sjogren's syndrome should really be much higher on the differential diagnosis than lupus. Lupus is not a demyelinating syndrome. It's, as we saw before, a vascular mediated syndrome. I'm going to end by briefly touching base about the vasculitides. The vasculitides are syndromes characterized primarily by inflammation of the blood vessel walls, and they can be understood by the size of the blood vessels which are affected. So the larger vessel vasculitides include giant cell arteritis and Takayasu's. The medium cell vasculitides include polyarteritis nodosa and Kawasaki disease. The small vessel vasculitides come in two flavors. There's a immune complex deposition, which includes the primary rheumatic disease such as lupus and Sjogren's. And then there are small vessel vasculitides which are not mediated by immune complex deposition. They're associated with a type of antibody called ANCA antibody, and these include Sjogren's, microscopic polyangiitis, and Wegener's. Remembering the names of all these vasculitides is not that important. The point I want to emphasize is on the right. The smaller vessel vasculitides give rise to neurologic morbidity by causing strokes, but the small vessels cause strokes of the peripheral nerves, so they present as asymmetric neuropathies. The larger the vessels affected, the more likely you are to go away from having a peripheral neuropathy and more likely to have strokes. In particular, giant cell arteritis can be associated with strokes, disproportionately affecting the vertebrobasilar system. Again, the important role of a neurologist here is when rheumatologists consult neurologists to go ahead and broaden the differential diagnosis. Again, because we want to make sure that we're treating an inflammatory syndrome. So one angiographic mimic of polyarteritis nodosa is called the segmental medialytic arteriopathy, which is a variant of fibromuscular dysplasia. This is an entity which can cause strokes in young women and is a non-arteritic cause of stroke and can present similarly with angiographic findings of thrombosis and aneurysmal dilatation. In terms of the small vessel vasculitides, there's a lot of pseudovasculitic syndromes which are a lot more familiar to neurologists because we look for them in routinely patients who come in with strokes. And these include atrial myxomas, subacute bacterial endocarditis, and cholesterol emboli syndrome. If you go to any neuroimmunology meeting, You go to any academic center, and no matter what the case is, one of the entities that's going to be on the differential diagnosis is this entity called CNS vasculitis. And having rotated through the vasculitis center at Hopkins, I could say with absolute certainty that for every one case of biopsy-proven CNS vasculitis, 99% of the times it's a mimic. And that's very important because we've seen patients come in on prednisone and Cytoxan, and the best thing that we do for them is take it off. Now again, why are they diagnosed with CNS vasculitis? Because angiographically they look the same. So someone with severe atherosclerotic disease can have an angiogram which looks like CNS vasculitis. Malignancy, especially this entity called lymphomatoid granulomatosis, which is a form of angiocentric lymphoma, can look like CNS vasculitis. Drug use, amphetamine, cocaine, also looks like vasculitis because it causes spasm of the vessels. And infections are another mimic of CNS vasculitis. So the take-home points is that neurologists are very important in these rheumatic disorders because neurologic morbidity is common and neurologists are specialized to recognize mimics. Neuropsychiatric lupus encompasses a broad swath of mechanisms. And in order to properly treat people, we have to appreciate that there's heterogeneous mechanisms which have corresponding diversifying treatment implications. And as I said before, these effective therapeutic interventions will require mechanistic-based algorithms. These algorithms have been accomplished for the primary neuroinflammatory syndromes. We've heard the diagnostic algorithms been for MS, for transverse myelitis, and as well as Devic syndrome. There's no way or no diagnostic algorithm right now for all these rheumatic disease. So I want to close by saying that I've completed the clinical year of training, and it's just been a privilege to take care of a lot of patients who come to Hopkins. And I just want to say that we admire the resilience and we learn a lot from you. And thank you very much for allowing us to learn from your care. Thank you.